In this chapter, we will discuss some more advanced skills in de-escalation, including managing teams, leading a debrief, and addressing your personal reactions to agitated patients. First, let's talk about managing a team during de-escalation. When a patient becomes agitated, there is often a team response. Technicians, nurses, and security all show up in a matter of minutes. Let's watch this vignette of a patient who was brought to the emergency department involuntarily by police after he was found acting strangely in the community.
And I went towards the back. It was small.
Hi, Norman. It's Dr. Albert. What's going on?
Did you hear that?
No, I didn't hear that. What's happening?
I walked to the back.
Norman,
and the thing
tell me a little bit more about what's helped you deal with what you're
Stop
experiencing
it!
right now.
Stop it!
That did not go well. Let's review where things went wrong. The provider started well. She respected personal space, surveyed the room, and saw that the patient was at least a bars of 5. She was concise and began to identify the patient's wants and feelings.
Things started to go poorly when other people arrived. Remember that agitated patients have a narrow range of attention and cannot follow complicated explanations or follow multiple people talking at the same time. Here, several staff are talking to the patient at once.
Only one person should be talking to the patient. This could be anyone who feels comfortable with de-escalation, maybe a nurse or a student.
The clinician engaging in de-escalation must be ready to direct others on the team who may be less familiar with the key elements of de-escalation. Let's watch this scene play out differently.
It was time. They were coming, and they were coming all together. They put that
Hey,
thing,
Norman.
it
It's
was
Dr.
coming.
Albert. How are you
They
feeling?
were coming. They were coming. And when
It looks like you're kind of upset right now.
Yeah.
No, just take a step back.
Yeah, when I just do what they tell me to do, and I was trying
You have to do what they tell you to do.
Yeah.
No, just take a step
I
back.
was trying to do what they told me to do, and they told me I need to go over there and get the thing.
So they're telling you have to go over there?
Yeah, I need to go over there and get the thing.
That sounds like it's really upsetting to you
Yeah,
at this
it is.
point.
It is.
Okay.
Yeah.
Do you want to sit down so we can talk about it a little bit?
But it's the thing that I have to go get.
So thanks for sitting down. So what thing are you looking for?
This provider made clear that she should be the only one talking with the patient. She used hand signals to maintain the patient's personal space, and she clearly informed the team to stand back. This provider also demonstrated one savvy technique for engaging the patient. She briefly matches the speed and intensity of the patient's speech. This has the effect of sharing a space with the patient. Then the provider slows down, bringing the patient with her. Be careful though, you don't want to end up yelling at the patient. So much of the de-escalation conversation is trial and error. Always revert back to the basic elements of de-escalation.
After the situation has resolved, it's important to debrief with the team. Any team leader may lead the debriefing. Effective elements of a team debrief include checking with team members that no injury has occurred, reviewing the events of the episode, asking what went well, asking what could have gone better, and inviting staff to talk individually if necessary.
Let's watch Dr. Rylander lead a debriefing after this episode.
Well, you guys, that looked really intense. Is everybody okay?
Yeah.
Okay. What happened?
Well, I was just walking by the room and I noticed the patient was pacing and looking like he was getting upset.
I heard some commotion, so I just came in to make sure that everything was okay.
There was an awful lot of talking going on. It sounded like maybe some calming was necessary.
Okay. What do you think we did well?
Well, I think it was good that everybody responded so quickly to try and help if needed.
Yeah, and I really appreciated you letting us know that you were okay.
Definitely, and that you had it handled.
Is there anything we think we could have done better?
I think it's important to remember that only one person should be talking at a time.
Mm-hmm. And I think maybe this patient was agitated in triage, so we maybe could have done a better job of helping him sooner.
Agreed.
Okay. Does anybody have anything else they want to add?
Nope.
Okay. Well, it sounds like we were able to recognize the agitated patient, keep everybody safe, and de-escalate him. If anybody has any other thoughts or concerns, you can always find me later.
Sounds
Okay,
good.
great. Sounds good.
Okay.
Thank you.
Thanks. We'll now talk about a less common but very scary scenario, the patient who has a weapon.
Tracy?
What?
Hi, I'm Dr. Seefeld. Can I talk to you for a
No,
minute?
I don't want to talk. I just want to leave.
Okay, I hear ya. Would you like to have a seat?
No, I don't want to have a seat. I just said I want to leave.
Okay, I understand. Unfortunately, we can't have you leave quite yet. We do have to do a comprehensive safety evaluation.
You know what? Get out!
Okay.
This scenario is rare. However, it's also scary, so let's talk about the appropriate response. This de-escalation started well. The patient was hyperactive and not responding to direction, so at least a bars of 6. The provider established verbal contact and was concise.
Even the best efforts at de-escalation may not work. In this situation, the patient pulled pepper spray on the clinician. There is no way to effectively de-escalate a patient when you yourself feel unsafe. As a clinician, you have no role in negotiating with an armed patient and should not attempt to disarm the patient yourself.
Dr. Seefeld immediately left the room to find professional security officers or police. If the patient asks to leave and you can't safely keep them in the clinic, you should let the patient go and immediately alert police. Managing agitation is difficult. Situations feel unpredictable and even dangerous. Many trainees and even experienced staff can feel overwhelmed at the idea of de-escalating a patient. Maybe they don't want to be yelled at or feel there's too much pressure.
The last segment of this video is a reminder to clinicians about one final advanced skill in de-escalation: remaining mindful of your own reactions and emotions. Maintaining a calm and respectful demeanor is important for successful verbal de-escalation. However, it's not easy. We asked a few of the faculty you have seen in this video series about the most common emotions that come up for them when de-escalating patients and how they handle those emotions in the moment.
So my main concern with agitated patients is always personal safety. So I think it's important to keep in mind how you can get out of a situation if the patient were to escalate beyond what you can control. And also just keeping yourself calm and so that you can keep a clear head and think about what you need to do in the situation.
Well, in dealing with an agitated patient, I worry the most about acute impulsivity relating mostly to a violent outburst. And so staying safe in the room and having the patient stay safe in addition.
I'm concerned about the safety of the patient, myself, and then the other patients and staff around me.
There are some tips to use for people who are training to de-escalate patients, and part of that is really practicing and being aware of your surroundings and being able to have some emotional control throughout that and being able to stay calm at all times, even if you're really not feeling calm on the inside.
I try to remind myself that it's not personal. I mean, unless it is personal, but no, normally it's, they're having issues that have nothing to do with me, and I'm just sort of the target that's available. And so that helps me to not engage with them when they're feeling upset.
I'm looking at verbal cues and also nonverbal cues of how the escalation is going. I also like to put myself in the patient's shoes to understand where they're coming from and why they're becoming agitated. I think that really helps to know where they're at in the escalation continuum.
One thing that I would want trainees to keep in mind when de-escalating agitated patients is their internal experience. Be aware of countertransference that you have with the patient. It's okay to be open and honest with the patient about what you're experiencing while still being sensitive to what the patient is experiencing.
Some of the things that I do to help maintain that emotional control when somebody's really getting agitated in my face is really putting myself in their shoes and understanding why are they becoming agitated. Knowing the origin of the agitation is key so that you can really understand why and how you can help.